So good evening, everyone. Welcome. I'm delighted to see all of you here this evening. Thank you for joining us to open the Colorado Behavioral Health and Wellness Summit. I'm grateful to each of you for the contribution you're making to improve the well-being of Coloradoans in our state. I've been incredibly lucky to work with some amazing people over the past year to bring this to life, including my fellow steering committee members, Dr. Nancy Lorenzon, Dr. Waltrina DeFrance DeFore, somewhere back there, Kim Lau from the University of Denver, Jerry Cunningham and Jazz Fitzgerald from Envision U, and then Karen Prestia from the Mental Health Center of Denver. So really grateful for all of their work. I also want to thank Dr. Clark, Rick Doherty, Jeannie Ritter, Darcy Cunningham, and Amy Sarazan from the Mental Health Center of Denver for their unwavering support of our work. Finally, we are grateful to each of our individual donors and sponsors. As a result of their financial commitment, we are able to offer all of the programming this week at no cost, and so the entire summit is open to the community. Okay. So my passion for this work is built upon personal experience. I grew up in a home impacted by mental illness and addiction. As an adult, I battled a substance use disorder and debilitating depression. When I felt the flicker of hope go dark, I attempted suicide. I'm proof that recovery happens when supported by knowledgeable and affirming providers. I love this quote by Nito QBN. Your present circumstances don't determine where you go. They merely determine where you start. By nearly every metric, suicide rate, the prevalence of mental illness, substance use disorders, vaping, and death from drug overdoses, our state is in crisis. It's estimated that about 20% of our adult population has a mental illness, which is about 832,000 people. And sadly, according to a 2019 report from Mental Health America, more than 600,000 of them are not getting the services they need. Additionally, 67,000 Coloradoans have a substance use disorder, and in the past 12 months have also been unable to access services and the help they need. And we learned recently that youth suicide is up in the state 58% from 2016. It's the greatest spike of any state in the nation, and it's the leading cause of death for Colorado's young people and youth. Stigma, fear, and lack of understanding compound the suffering of those affected and prevent the bold action that is so desperately needed. Historically, Colorado's efforts to make mental health services effective, accessible, and affordable have been inconsistent at best. Thankfully, under the leadership of Lieutenant Governor Diane Primavera, Michelle Barnes, the Executive Director of the Colorado Department of Human Services, the Polis administration, along with many leaders in the state capitol, including Leslie Herod, have an ambitious plan to remake the delivery of mental health care services in the state. With the determination of all of us, we can work to impact meaningful change. Hopefully, through the workshops and trainings offered this week, each of us will have a renewed sense of purpose and determination to help those suffering and to encourage family, friends, and neighbors, along with colleagues and the people we serve, to discover a life worth living through better mental health. I'll leave you with one last quote by the author Susan Sadler. Never give up on someone with a mental illness. When I is replaced by we, illness becomes wellness. So thank you again for joining us. It's really grateful to see all of you. I know we have some just amazing workshops this week, and so I hope in addition to joining us tonight, you will join us for one of the 37 amazing workshops that we have. So I'm pleased to introduce to you the co-chair of the Colorado Behavioral Health and Wellness Summit, Dr. Nancy Lorenzo.
Thank you, Stephen. I'm just so happy for the turnout that's here tonight and the turnout that all the registrants that have shown interest in all the different workshops throughout the rest of the week. It really shows the incredible interest, need, and concern for the health and well-being of all of Colorado. Tonight, we are joined by clinicians, educators, students, policymakers, and community members to address some really critical concerns. Mental health issues and substance use continue to challenge good health and well-being in the state of Colorado and in the United States. I'm a teaching professor in biological sciences and director of pre-health advising at the University of Denver. My interests and passions are health education and health equity. I mention this to begin to explain how this summit came about. I wanted to better educate the student body and DU community about some of the current issues related to substance use and the intersection of mental health and physical health. In January, just this past January 2019, I was incredibly fortunate to be introduced to Stephen Hayden at the Mental Health Center of Denver. Stephen told me about a new initiative that he and Jerry Cunningham had founded, Envision You, an initiative to address the intersection of the LGBTQ plus community, mental health, and substance use disorder. If you know Stephen, you know he sets huge goals and gets things done. From this meeting in January, the summit was born. The University of Denver, the Mental Health Center of Denver, and Envision You joined forces to create the summit as we share a common collective commitment to encourage neighbors, friends, family, and colleagues from around Colorado to learn more about behavioral health issues and substance use disorder. We know we have a long way to go in terms of making mental health and substance use treatment available and accessible to all of Colorado. In the next several days, we're going to engage our community to break down silos statewide and to bridge gaps in communication and collaboration. We hope to discover new tools and resources, discuss practical strategies for change, and connect with colleagues and experts. We hope this community collaboration will foster an increased focus on tackling these difficult issues. The behavioral health concerns in Colorado and nationwide have been recognized by community, healthcare providers, institutions, and also policymakers. Who better to make opening remarks and ignite a call to action but a steadfast patient advocate, Lieutenant Governor Diane Primavera. A little bit about the Lieutenant Governor. Diane Primavera is a leading patient advocate who has spent 3 decades fighting for every Coloradoan's access to quality, affordable health care. As a young mom in 1988, Diane was diagnosed with breast cancer. Her doctor told her that she had, at most, 5 years to live. Since her first diagnosis, Diane has fought cancer 4 times and survived. Her personal battle with cancer inspired her to make it her life's work to ensure that every Coloradoan has access to the health care they need when they need it. In 1990, Diane joined the Rocky Mountain Regional Brain Injury Center, where her work focused on helping individuals dealing with serious injuries to recover and resume dignified, fulfilling lives. Since then, she has held many prominent positions throughout the public and nonprofit sectors, devoted to furthering life-saving medical research and connecting Coloradoans who experience illness with the treatment they need to recover. In 2006, Diane was elected to the first of 4 terms in the state legislature, representing Broomfield, Superior, and parts of Erie. Throughout her service, Diane was highly regarded for her success working across the aisle to promote Colorado small businesses, lower prescription drug costs, and expand access to affordable health care. Most recently, Diane served as the CEO of the Susan G. Komen Colorado, one of the largest organizations in the country dedicated to breast cancer prevention, treatment, research, and education. Diane is a lifelong Coloradoan and a Broomfield resident. She has 2 adult daughters and a 2-year-old granddaughter. Diane is also an avid ballroom, country, and Latin dancer, taking after her dad, who is a dedicated ballroom dancer throughout his life, even on his 95th birthday. So amazing health there. It is now my pleasure to introduce to you the Lieutenant Governor, Diane Primavera.
I'm a little vertically challenged, so anyway, thank you, Doctor, for the introduction and inviting me to join you this evening. I'm glad you're all here at this summit to collaborate and discuss practical strategies for change and connect with colleagues and experts alike. I want to thank you all, clinicians, educators, researchers, policymakers, and leaders in the field of behavioral health, for your commitment to our family, our friends, our neighbors, all who are working through substance use and/or mental health challenges. Tell you a little bit more about myself personally. I started off my career, my professional career, as a vocational rehabilitation counselor. I worked with people who were physically and/or had physical disabilities and/or mental illness to try and help find them jobs. I found it easier to find people with physical disabilities jobs than I did to find people with mental illness jobs. And so I learned firsthand how strong the stigma is against people with mental illness. And unfortunately, behavioral health struggles are something that I'm personally all too familiar with. My favorite brother, an accomplished attorney, faced mental health challenges in his later life. He was diagnosed with bipolar disorder, but he continued to resist help, leading him to withdraw from his family, gamble away his retirement savings, and ultimately lose his job and his career. He lost his will to live and ultimately succumbed to his struggles. And unfortunately, this story is far too common in Colorado. According to Mental Health America, about 20% of the state's adult population, around 832,000 adults, is living with mental health condition. Worse yet, nearly half of them aren't being treated for that illness. The results are daunting. Our national suicide rate climbed by 33% from 1999 to 2017. And simply put, we need to do a better job serving those Coloradans struggling with behavioral health challenges. Many national rankings place Colorado in the bottom quarter of states when evaluating the quality of behavioral health care provided to residents. Colorado ranked 43rd out of 50 states for the prevalence of mental illness and access to care. And Colorado also has among the highest suicide rates in the country. We can and we must do better to transform our system for Coloradans living with a behavioral health condition so that they can access affordable, high-quality, and patient-centric treatment. Improving mental health and preventing suicide is a complex and delicate issue. It requires a holistic approach through upstream prevention, early intervention and treatment, and post-intervention measures. For starters, we need to improve access to mental and behavioral health care. A major barrier to accessing mental health care, of course, is cost, which is why our administration's efforts to reduce health care costs are absolutely critical. We're proud to have delivered a slate of proposals in conjunction with our legislative partners that will lower the cost of health care, short and long term, and I'll go through a few of those with you. With the legislature, we are establishing a reinsurance program that will lower premiums an average of 20% across the state for people who buy their insurance on the individual market. We capped insulin prices at $100 a month. We passed legislation to lower the cost of prescription drugs by importing medication from Canada so Coloradans can get the same quality medication for much lower costs. We're also reducing out-of-pocket costs by bolstering consumer protections like prohibitions on surprise out-of-network billing. And the governor signed a bill to increase hospital price transparency so that we can pull back the curtain and identify and address the causes of outrageously high hospital bills. We're working across many medical fields in order to increase the scope of care for qualified medical professionals to drive down costs and improve access to high-quality care for individuals. And the governor signed legislation creating the framework for a state-based insurance option. This will give Coloradans more health care choices and will bring down costs by injecting competition into the healthcare market. But as you know, cost isn't everything. Another major barrier to mental and behavioral health care, as I mentioned before, is stigma. We must continue to do more to activate community networks and encourage those at risk to seek help within those networks, and do all that we can to reduce stigmas associated with seeking treatment. This requires collaboration between state and local governments and nonprofits to promote treatment options, along with specific strategies focused on at-risk populations like LGBTQ youth, Native Americans, farmers, ranchers, and Coloradans living in rural areas. While these are complex challenges, it is one that we must take head on to save the lives of our loved ones, our friends, and our neighbors. So Governor Polis and I take this charge seriously and have laid the foundation to evaluate our state's current behavioral health system and to develop a statewide strategic plan to reform our system through the formation of the Colorado Behavioral Health Task Force. And I think Michelle Barnes is in the audience tonight, right down here. And I just wanted to commend Michelle for tackling this head on and putting a great staff around the effort. So thank you, Michelle. So our goal with this is to ensure that every Coloradan experiencing behavioral health needs can receive timely, high-quality, and cost-effective services in their communities. Too often, individuals living with behavioral health challenges experience homelessness and trauma, and sadly, all too often, they find themselves involved in our costly criminal justice system or expensive emergency care system, receiving services much too late and not appropriate and at taxpayers' expense. So we need to streamline access to quality services that enable Coloradans experiencing behavioral health needs to obtain an education, enjoy their childhood, find and hold gainful employment, and live productive, happy lives. And we know that providing upstream care and services through community behavioral health programs promotes the health and well-being of our citizens and also ensures that we're using state resources effectively. This task force will build on the good work of local and state agencies, service providers, and stakeholders from across the spectrum and embrace a holistic approach to the challenges that our state faces while exploring creative and innovative solutions also. The task force includes members who represent diverse and balanced perspectives on these issues, such as consumers and families who are dealing with mental health issues, key executive agencies representing state and local government, criminal justice experts, advocacy groups, and behavioral health experts. The Behavioral Health Blueprint, which will be completed by June 2020, will outline detailed steps and implementation timelines for desired changes that will improve the efficacy and efficiency of our behavioral health system. So Governor Polis and I are proud of the work that we've done this far to address our behavioral health crisis, but know that there are still Coloradans in our community who are struggling. Fortunately, we're not alone in this. We have dedicated partners in you all and would not be able to make an impact without you. So thank you all for the work that you are doing here today to collaborate, break down silos, and bridge the gaps in communication to address our behavioral health needs. I hope you have a wonderful summit, and we look forward to working with you in the future.
All right, so the next speaker's name is on my paycheck, so I better get this right. Clark. Dr. Clark is the president and CEO of the Mental Health Center of Denver and inspires a culture of innovation and well-being that motivates employees to deliver evidence-based practices that are strengths-based, person-centered, culturally proficient, and trauma-informed. He has dedicated his career to improving the well-being of the Denver community and beyond through a focus on health promotion, wellness, resilience, and recovery across the lifespan. Dr. Clark has extensive involvement at the local, state, and international levels, working with leaders to elevate the importance of behavioral health care. Under his leadership, the Mental Health Center of Denver has recently been named one of the top workplaces by the Denver Post 7 years in a row. And just last year, we won the 2018 Excellence in Behavioral Health Care Management Award from the National Council for Behavioral Health. Please join me in welcoming Dr. Carl Clark. There you go. Thank you.
Mom would have liked that. Imagination is what makes us uniquely human. We imagine things that never existed in the world before, and together we can create those things in a way that's never been. So this summit really gives an opportunity to think about how we would really like things to be. So I'm going to talk a little bit about where we are in mental health, and what imagination can do and accomplish. So that's me at our organization. The first thing we do is focus on what people are naturally good at. So we have people take StrengthsFinder so that they can know what they're pretty good at and be great at it. Here's some of the things we've done. I'm Dr. Carl Clark. I'm the president and CEO of the Mental Health Center of Denver. Our mission is enriching lives and minds by focusing on strengths and well-being. So in 2017, we opened the Sanderson Apartments. This was a 60-unit apartment building that was for people that have been on the streets and homeless. It's been a great success. Not only did we get people into the apartments, people have gone from not working and not being engaged in school to almost everybody doing one of those activities. We've also been recognized nationally for a couple of things. One is our co-responder program. That's a program where we send social workers with police officers on calls where there might be a behavioral health issue, either mental illness or addiction. It's been remarkable what's happened with that program. Our co-responders have seen almost 1,000 people, and 99% of those people have gotten what they needed as opposed to being arrested. Our Dahlia Campus for Health and Well-Being was recognized by the National Council for Behavioral Health, and we won the 2018 Excellence in Behavioral Healthcare Management Award. We were recognized for a model that engages the community to create the types of services that can help a community thrive. So our vision is that everyone who lives in Denver who needs access to any type of behavioral health care, whether that's for mental illness or for addiction, that people get access to the care that they need. Denver did a really great thing this year. They passed the Caring for Denver ordinance, which was a 0.25% sales tax for money dedicated to meeting people's behavioral health needs. Denver voters are saying, we want something to happen here in Denver. Here's an interesting thing. The better your well-being is, the better it is for everyone around you. So I'm inviting you to take the Science of Well-Being course that's offered for free
by Yale University.
So that's imagination. It's your gift to the world. So we've talked some about the numbers. We heard from the Lieutenant Governor. It really is about 1 out of 5 people that are dealing with a mental illness or an addiction problem. And of that group, only 2 out of 5 are getting access to care. So 3 out of 5 are not getting access to what they need. Now that group is interesting. It's for a lot of different reasons. The most common reason is people don't know where to go. They don't know how to connect with services. And we need to think of ways, imagine ways that that could be different. There are a group of people in that group that don't think they need help. And that's interesting too, because it's actually 2 different types of folks. One is the group of folks who they know they do need help, but they're just not ready for it yet. And then there's another group that it's actually a symptom of their illness that they have the inability to know that they're ill. It's called anosognosia. And these are often the folks that we see out on the streets. We have an outreach program for people that are homeless, and there are folks in our community that a lay person could say something is not right here, but that person themselves doesn't experience their life that way. It's a very difficult group of people to connect with. Now, what we do in treatment is basically 3 things. Somatic treatment is really about doing something with the body. And that might be a medication, it might be transcranial magnetic stimulation, it might be helping people eat right, to sleep better, to get exercise, all those things that happen to a body that helps the mind be healthy. The second thing we do is psychotherapy, and we do all types of psychotherapy. And it's the evidence is there that changing the way people are thinking about things, feeling about things, and their behavior can be done through psychotherapy. Our psychotherapy goes beyond just the psychotherapies for illness. It includes the psychotherapies for positive psychology. So how do you move somebody from doing just fine to actually thriving in the community? One more thing there. Social determinants is the third thing that we do. And those are all the things that actually have a bigger impact on your overall health than even anything any clinician can do in any discipline. So those are things like having a safe place to live. So we do affordable housing. Helping people go back to school, helping people go back to work. Those have a tremendous impact on people's overall health. Now, we're all, and this is what Leslie Herod was saying earlier, we're all somewhere on this continuum. So when I say mental health, people think mental illness. It's interesting, isn't it? Because we all have mental health. And we're all somewhere on a continuum. Most of us are doing just fine. There's probably folks right here that are actually thriving. And then there's those things that happen, the ups and downs of life, where things happen and impact your mental health. Sometimes that can result in an illness. And then most people who develop an illness will recover from that. There are some folks, through genetics and circumstances, develop very difficult illnesses. And that group of folks needs our respect, they need our protection, and they certainly need access to care. So mental health has evolved over time. In our country, in the 1800s, if you were not acting right, you went to a place that pretty much looked like a jail. In fact, right now, today, you can visit places where there are 2 buildings side by side. They're built exactly the same way. If you were a criminal, you went into the one building. If you were mentally ill, you went into the other building. Dorothea Dix, through kind of a civil rights advocacy, said putting people in jail for being sick is wrong. And that's actually what started our state hospital systems across the country. And the state hospital systems were a place where people were protected, but the treatment was not very advanced. And we wound up warehousing many people in those institutions. Advent of medications and a variety of other things, We were able to move people out of the state hospitals and into the community, which has started the community mental health movement. In the beginning, it was more, the approach was illness management. It wasn't about like really even getting the illness to go away. It was just taking care of somebody with an illness. Then the treatments got better. Then people got onto the idea that health is much more than the absence of illness. And what are those things that we can do to help somebody do well in their life? And that started the recovery movement, which was buying into the idea and knowing the data that people can and do recover from mental illness. We're now shifting again, adding in positive psychology to look at how do you take somebody from doing okay to actually thriving in the world. The science has not been around that long. It's only been around for about 20 years. So Martin Seligman is a psychologist. He's at Penn. And he was the head of the American Psychological Association. And he had studied very interesting things, difficult things, like genocide, learned helplessness, those sorts of things. And when he became the head of the American Psychological Association, he said, we study what goes wrong with the brain. Why aren't we studying what goes right with the brain? And this is really the starting of the movement of positive psychology. His first book is Authentic Happiness. It has a smiley face on it. He hates that cover, but his publisher said that will make it sell. And what's happened over time is a construct looking at what are the elements that contribute to somebody's well-being. It's called the PERMA model, and I'll talk a little bit about these. So the first thing is having positive emotions. The more positive emotions you have, the better your well-being. And there's even a ratio that people talk about that if you have 3 positive emotions to every 1 negative, you're actually thriving in the world. If it's 1-to-1, you're just kind of doing okay. And if it's the opposite, you're likely not doing well at all. Now, positive emotions are an interesting thing because you know whether you're having one or not. It's subjective. So I will give you an example. I have friends that jump out of airplanes, and they like it, right? I would not. So that's an example of you can't just take the situation and say that will cause a positive emotion. It depends on the person's response. The more positive emotions you have in your life, the more you will have in your life. And there are things that you can do to increase positive emotions. The second thing is engagement. And engagement is when we're so involved with things that time sort of like disappears. And it can happen in a variety of settings. And the more times you have where you're deeply engaged, the better it is for your well-being. Again, this is subjective. Sometimes you don't know you were engaged until after it's over. Sometimes you know it while you're in it. So when I'm playing the piano, I know I'm engaged right then at that moment. The third thing is positive relationships. This is actually more objective. You can look at people's relationships and determine whether they're positive or negative. The more positive relationships you have in your life, the better it is for your well-being. The M stands for doing something meaningful. We all want to do something meaningful with our lives. And when you engage in meaningful activities, it contributes to your well-being. The last one is achieving things, accomplishing things. It can be little things, it can be big things. It can be starting a family, it can be, I got the garage cleaned. So being engaged in stuff and getting things done contributes to your overall well-being. Now, there are different types of well-being, and these are actually in order of the most impact on your life. Your career has the biggest impact on your overall well-being, and most likely because your career is where you're doing something meaningful with your life. Relationships are the second most impactful. The third is actually your financial well-being. And we live in a country where we have great disparities when it comes to finances. And if people don't have the basics, it does contribute to their well-being not being good. The last one, or physical well-being, of course, is important, but the last one's community well-being. And the science here is really fascinating. So it is true, the better your well-being is, the better it is for everybody around you. This is what the science shows us. If you have a friend whose well-being is good, they have a 15% influence on your well-being to the positive. If you have a friend who has a friend whose well-being is good and you don't even know them, they have a 6% influence on your well-being. And then it goes the opposite direction too. If you have a friend whose well-being is not good, the percentage isn't the same, but it's a 6% influence on your well-being to the negative. So as it turns out, we are all very connected. The Gallup Group looks at well-being by cities, and they look at well-being by states. And Denver, of the top 50 cities, we're actually number 18 in well-being. So we live in a pretty good environment. You know, we're not number 1, but we're not number 50. I would like us to be number 1. When we look at Colorado as a state, we're actually number 7 in well-being. So we live in a really healthy state. And the thing about living in a healthy state, you can move to even a healthier place. So let's talk about some of the challenges that we have in behavioral health. Access to care is the big one. You know, if 3 out of 5 aren't getting it, we've got to do something about that. We've had parity laws, which means that mental health, behavioral health needs to be paid in the same manner that we do physical health care. Those have been on the books for 11 years. It's still not happening. It's kind of hard to prove. It's hard to make a case. Fortunately, we have an attorney general in Colorado that's ready to take that on if he can find cases. The issue that we find in health plans is that they have a provider list that look pretty robust. If you call the provider list, though, the answering machine will tell you they're not taking new patients. So there's a question about whether those are really adequate networks or not. We definitely have a maldistribution of therapists in our state. So, and even with the maldistribution, every single county except one, which is Larimer County, is a health provider shortage area when it comes to behavioral health, including Denver. So, and then we need to talk about how do we actually access care. Now, I can tell you, and I've got some resources for you here at the end, I can tell you that if you have a friend or a family member that's not doing well, we have a walk-in clinic that's open 24/7 at Claremont and Colfax. It's easy to get to. You don't need an appointment. Somebody's not doing well, you just go there. Now, if your friend or family member is really ill and they need to go to the hospital, take them to the hospital. But if they're just like, need to get things checked out, go there. That works great, right? Except I think most of you probably didn't even know that. So how do we get word out about people accessing care? And then the other thing is that if you have to go somewhere to access care, maybe that's a barrier in itself. And when are we going to have the day where we have a digital front door to what we need for behavioral health? That's what we imagine happening in the near future. Our workforce is shrinking. The past 10 years, the people doing behavioral health has gone down 14%. So the number of folks that do this work is this big, and yet the need is this big. So how do we help that small workforce meet the needs of the whole community? We're going to have to use our imagination, leverage technology, think about all the things that can be done outside of that face-to-face relationship that can help people in their care. And then the funding challenges are pretty straightforward. It doesn't matter where you look on the whole planet, the need is this big, the resources are this big. So when it comes to behavioral health, every country on our planet is a developing nation. Nobody has solved this issue. So we've heard about the crisis that's here in Colorado. A brief note on that, in 2017, we had over 1,000 people die of overdoses in the opioid epidemic. And a part of that was the opioids being laced with fentanyl. 81 of those folks died because they took a substance that they didn't know had fentanyl, and it wound up contributing to their demise. Now, when you go somewhere, it doesn't matter where you go, you hope there are people that look like you when you get to that door, right? You want that connection. We put a big emphasis on having as diverse a workforce as we can. There's lots of things that you can do that creates an environment where people want to work within a facility. We have employee resource groups for folks of sort of different backgrounds to connect with one another and to do their work. And certainly safe space is important to us. You heard what Leslie said. I'll just say ditto on that one. And the last thing that I have here is about the most popular course at Yale ever in its entire history. It's the Science of Well-Being. It's taught by Professor Laurie Santos, who recognized that Yale students were not thriving, not doing well. It comes from the field of positive psychology. It's online, it's for free, anybody can take it. I learned recently from somebody that if there's something that's good for you, your resistance goes up about doing it. So I have offered this course to lots of people, and it's like a third do it, and they always thank me for taking the course. A third said, I signed up, but I haven't done it yet, and the other third said, oh yeah, I should sign up for that. So all of my board has taken this course. All of my executive management team, we encourage all of our staff to do this course. It really gets down to sometimes what our brains think will make us happy actually doesn't make us happy at all. And what are those elements that truly do? It's a 10-week course. There are no assignments. There are rewirements. You watch a video of her teaching this course in front of Yale students that ask really good questions. And then you learn about what can go right with the brain, and that week you do that thing. So I think we have these handouts up there. So it's both about the science of well-being that I just talked about, also other resources that we think are helpful for folks, and how to connect with the crisis services. So that's it.
Thank you very much, Dr. Clark. So there's lots of great opportunities to engage in conversation about what are some of the ways in which we can make a difference. So right now, I would like to shake things up a little bit, and I would like to invite you to hear a little bit from different people in our community who work in different sectors that are engaged in mental health, substance use disorder, and other aspects of some of the challenges that we're seeing in Colorado. So I'd like to introduce first our moderator, Don Stader. He's the Associate Medical Director and Emergency Physician at Swedish Medical Center and CarePoint Healthcare, and he'll be moderating some of the discussion tonight. Also, our panelists are Michelle Barnes, who we've heard as the Executive Director of the Colorado Department of Human Services, Dr. Michael LaFar, Executive Director of Health and Counseling at the University of Denver, Dr. Jennifer Tippett, Director of the Substance Use Disorder Specialty Program at the University of Denver's Graduate School of Professional Psychology. So I'd like for them to come join us on stage.
Thank you so much, Nancy. Okay, well, good evening. How are you guys doing? Wow, that was rousing. Thank you. How are you guys doing? Woo! Great. So I have the great pleasure of moderating this panel of people who are far smarter than me. So I'm going to try to do a good job of asking questions and then keeping my mouth shut. I have always been fascinated by how people got into their roles. And each one of you have a different journey to the position that you're now in and a different reason for why you're passionate about it. So we're going to start at the end with Michael, and we'll come across. And I'd just love to hear about what got you into the role that you're in and why you're so passionate about it.
Thank you for that question. I think I'm a clinical psychologist by training, and I think many of us in the helping field come to this experience of this profession and from sort of influences of some of our past experiences. I moved here 3 years ago from Boston and had an experience where I was 2 o'clock on a Saturday afternoon on my way for a massage, taking care of my health and wellness. And I was brutally attacked by a gang and suffered with PTSD. And it was through this experience of both that day in the folks, from the police officers to the ER docs, to the folks who, I'm sure it was, quite startling for the passersby who saw my sort of damaged body and what was there, and how did people respond. I think as you make your way through these major life experiences, you're touched by a lot of people. And I went to the trauma center. Some of you know the trauma center in Boston. Been doing some cutting edge work for a long time, and engaged, and it was in the care of Dr. Marla Zucker, a wonderful psychologist. And through that experience, I would say that I was able to reclaim my life and go from not being able to leave home and the terror and fear and the flashbacks that were a part of my life to leading a full and productive life. And I thought after that experience, I was 35 years old, I was well into a career, I was working at Harvard, I had it all. And my life changed at that moment. And I wanted to do what she did. I wanted to help to figure out how to help a person, in me, from my experience. She helped me reclaim my life from living in terror. And I wanted to do that. And so I went back to school, earned my doctorate in clinical psychology, and have had the gift of working with people no matter what their journey or how they got to be with me. And it's been one of these talking about positive experiences, about being able to join people in their, as they're trying to make their way through their issues and lead a more positive life. I think it really was turning something that was so tragic for me, and I wanted to use it in a different way. And I think that life experience really helped impact and change the way that I was sort of living my life. And it was that experience.
No, that's amazing. And it's amazing how you've taken something that for some people would be so detrimental and so destructive and make it into something that now is so meaningful and allows you to help others. So thank you for being on the stage. Jennifer, how about your story?
How about now? Yeah, okay. I think, like Michael mentioned, a lot of us in the helping profession come in all sorts of ways, but for me with substance use disorder specifically, it was seeing all of these really well-meaning programs that didn't work and were actually hurting people, and then a lot of disparity in what people could access based on how much they made. So even, as a graduate student, there was this program in Colorado where they took individuals with drug-related offenses and put them in an inpatient treatment program and in a halfway house, and just sort of scoop them up and put them there. And I'll never forget, we had one client who they put there and they didn't send his psych meds with him. And then he was labeled as resistant because he couldn't sit through the 6 hours a day of treatment that he needed to do. And it was just very punitive. And that client later went out and overdosed on heroin and died in downtown Denver, unfortunately. So watching how we stigmatize even within these places where we say we're not going to, but we do anyway. And then I was living in LA and I worked in community mental health and also at a rehab in Malibu. So I would go from my clients who had access to clinical psychologists who were completely trained and they had all of these luxury pieces to my clients in Ventura County who had nothing. They had no idea where they were going to sleep at night. And because they didn't make enough to pay 60 grand a month out of pocket for rehab, they were not going to get the services that they needed. So I really became passionate about training clinicians to do a better job of treating substance use disorders and being able to create better programs that actually respond to what people need instead of what we think that they need. So that is why we've created the program that we have.
Thank you.
Okay, hi, I'm Michelle, and I took a little bit different path to running human services in the state. I worked in for-profit business for a long time. I worked in the nonprofit sector, but I always felt like, I bled for the world. Like I had the heart of the world, and I couldn't enter a situation without feeling compassion and empathy and love for what I was interacting with, which made it pretty interesting because I worked at Facebook for a few years. So you kind of mix like what my career was and kind of who I was as a person. And I recently, when Polis got elected, I got an opportunity to interview for this job, and I was able to explain that I had a good overview of human services, but that I was really a business person, which is exactly what he wanted. He wanted somebody to come in and think pragmatically as well as heart and be able to blend both of them. So I'm in charge of the Behavioral Health Task Force for Colorado, which we're trying to reform the system. And the first couple weeks I was in my position, you'd have these series of discussions with the governor, and he'd say, here's what I want you to prioritize, and you'd say, here's what I want to prioritize, and give and take back and forth. And I went in, thinking I'm going to do foster care, or, I had all these ideas of what I was going to prioritize based on just personal passions and where I'd worked. And he had his ideas, but I said, I've worked here a week, and everybody I've talked to has told me behavioral health is an issue in Colorado. I've been here 2 weeks, and all I hear about is substance abuse. I'm now in my 3rd week, and mental health underlines everything we do. And so we settled on taking the bold move of putting someone with no mental health background, I'm the only non-doctor sitting up here, in charge of system reform. And I couldn't be happier about it because I do have outside eyes, so I'm looking at it a little bit differently, but I'm also not bringing my own bias. I'm able to hear people's stories and hear what's going on and really figure out what's the best thing we can do for all Coloradans. So this is like the most bizarre series of coincidental things that ended up making me here. But as I was just telling them earlier, I feel like I'm getting a master's degree without having had the benefit of getting an undergrad degree. So I'm learning very quickly, and I'm appreciative of so many people sharing their wisdom.
So you mentioned one word, and you talked with me a little bit about it before we got on stage, which is bold. The governor told you to be bold in terms of reforming healthcare, especially mental health care. With your task force, how are you guys planning to be bold, or what are some of the policy ideas that you've been kicking around?
Yeah, that's a good question. It would be really easy just to come and say, well, we need to do another PSA campaign, a public service campaign on stigma, or we need to pass this one bill, or we need to ask for more money to do this. But that's not really bold. That's just incremental thinking, and it's at the margin. And what we're really trying to do is say, what would change this system? And I think the fact that most of you are here, I'm sure you know that our system is not working for a lot of Coloradans in spite of some amazing people in the system and some amazing programs that are working very well. But the system itself isn't working. It's access, it's affordability, it's
it's a lot of different things that aren't working. So we're looking to really say, not being bound by where we are today, 5 years from now, where could Colorado be? And then let's back out and say, what do we do in year 1? What do we do in year 2? What do we do in year 3? But not be held back by the realities of, tight state budgets and not enough providers, which is a huge issue, and rural communities not having the resources they need, and an opioid epidemic, and having one of the worst suicide rates in the country. And Colorado's rated on the mental health index, I think we're 44th in the country. So while we have a lot of things to be proud of as a state, mental health is not one of them. And so trying to really be bold and say, how could we be in that top 5 of states? How could we do things significantly better, which means we need to really push each other. And the first round of kind of recommendations on the task force were pretty incremental. And now we're trying to get to things that what would really make a difference.
So great. So Jennifer and Michael, you both are deep in the mental health world. You have right here the task force leader of the governor. What would you tell her with being bold? What would you advise her to how to improve our mental health system?
Like a wish list?
Make a wish, sister.
I think one of the, I was thinking about this idea of bold and doing things differently, and one of the things, in some ways, a university is a microcosm of sort of a city or a community, and I'm reflecting both on the bold question, how do we address and do things differently, because as you said, it's not working. And one of the things that we have done here is we've said, okay, individual psychotherapy is a wonderful, beautiful thing, but some people may not be ready for that, may not have access for that. What are some of these other ways that you can be doing it, supporting people? And one of the things that we've just initiated here is telemental health for students, and we've given it to everyone without a cost. And I think we're going to see over the long term that there's going to be quite a return on that. It's been, the institution has thought, okay, we can't keep up with this. Folks are online, they're all over. So I think, one of the questions that I think about is, are there things that we haven't used historically, like perhaps telemental health, that we can make accessible to some of our Coloradans in rural communities, for example, folks who are underinsured. So it's just an idea, I don't know, I guess I'm just floating, is are there things like telemental health that we could provide for all Coloradans that would help a stopgap in some way? I guess that was a rhetorical question, but I'm just thinking about, are there things like that we should be considering?
Absolutely. And I'm glad you brought that up. That's one a lot of our providers are bringing up, that we need to think differently other than just one person face-to-face, especially when you start talking about the vast number of people that need mental health services and the shortage of workers, and then the fact that if you live in a rural county, there may not be more than 1 or 2 mental health providers in your community, and they may be your sister and your ex-boyfriend, so you don't have the same options you might have in Denver.
Well, even within Denver, I mean, if you, say, miss your bus, or the bus is late, and now you've missed your appointment at MHCD, and now you're back, you don't see your psychiatrist for a month now. And so even within an urban population, it can be really difficult for people to access. So I think telemental health is such a great idea. It's such a great way to sort of overcome some of those barriers.
So here's a bold thing that you hear battered around, and that's an absolute lightning rod for the addressing the opioid epidemic, is supervised injection centers, right? That's a very bold idea that's been advanced by some different proponents around the states. What are your thoughts? And we'll start with Jennifer, because you're big into harm reduction. What are your thoughts about a policy like that, a supervised injection facility?
Yeah, thank you for that. I really tend to look at addiction as an issue of disenfranchisement in by and large. And so when we take people and we marginalize them and then we marginalize them further and we push them and push them and push them, it becomes a really ugly cycle in which they don't have any pathways back into society. I really think that safe injection sites provide people a way back into society. So it is not handing someone a needle and saying, here, go shoot up, we don't care what you do. It really is, come in, let's talk, let's be in a safe place. Here's some access to a mental health worker while you're at it, just in case you want to chat, right? It provides avenues for people to start talking and looking at their addiction instead of sitting in a street corner or an alley someplace where they have access to no one and they are alone.
Other thoughts from the panel? I'm very interested to hear your thoughts, Michelle.
I'm not sure I'm an expert on this, but I can tell you one of the things we've been experimenting with, and we're doing a lot more this coming year, is making sure we're getting MAT, or medically assisted treatment, to people where they are, and trying to help them deal with their addictions with the right medication at the right time. And we're even rolling out later this year vans that'll be going out to rural communities to administer this, and finding ways we could administer it. So I think the more we can get treatment to the people in a way that they can receive it, we can destigmatize it, and we can help them not continue down, I'm completely in favor of.
So, we're starting to transition. I have another question, and one that's actually a personal one for this community. A few years ago, there's a very high-profile overdose that happened on DU's campus, where a young man by the name of Jonathan Winterfield, who is the son of the former vice chair of the Joint Chiefs of Staff, overdosed right here on this campus. Let me ask you, what has been done since that time to make sure that we're looking out for the warning signs of mental health and substance use disorder within the collegiate ranks, and assuring that there's never another Jonathan Winterfield?
Yeah, thank you for that. This community was deeply impacted by the loss of Jonathan. Jonathan's dad, as you said, is a former admiral of the Navy, so he has been on TV and talked a lot about the loss of Jonathan as he was here in his first few days in orientation. I think it was a shock for this community. I think, like many communities, we sort of saw the opioid issue as an issue that was impacting other communities, and I think that's probably true across the country. Why this has taken so long for us to address it is that I think particularly with heroin, I think we really saw that there were a lot of it was an issue impacting marginalized populations, and it wasn't, I think, until it started impacting more of mainstream America that we started really taking this seriously. And I think in some ways there was some parallel processes that were going. Jonathan died on September 7th, 2 years ago. And the community was rattled. And what do you do out of that? And I've met with Mary and Sandy multiple times. They really were looking for services and looking for us to sort of step up. Out of that came the collegiate recovery community here. We're in our first year. We have over 30 members. We have a director, and I'm searching for a coordinator now. Our director is extraordinary. We have 30 members, and as compared to other collegiate recovery communities around the country, some are in year 3 and 4 and just building that. So there was a need here. I think many folks didn't recognize it, and Sandy, we've got a great relationship with Sandy. He flies out every few months, and he's on the phone with Waltrina, who's the director of our community, on a regular basis. So I think out of that, we've said we've got a responsibility to the community, and we had to address the stigma, because for a lot of our communities, a lot of members of the community was sort of like, well, oh my gosh, that issue is here. What are you doing about it? And there was a lot of fear. But I think what people are seeing now is that supporting people to thrive in their recovery is the biggest gift that we can get. I think there are lots of ideas. Is this a inpatient, just an inpatient treatment center? What's happening over there? And what they're seeing is it's a supportive community that's helping one another in maintaining their sobriety, and they're thriving. And I'm really proud of what's been able to have been built and come out of that tragic loss.
So how do we protect more young men and women from, I guess, succumbing to a mental illness? How do we build a system that better cares for and identifies young men and women like Jonathan and gives them the support that they need? Open-ended question.
I'll jump in with one thing we're doing. Colorado as a state is embracing this new federal legislation called Family First Prevention Services Act. It passed about a year and a half ago, and states are opting in. And it basically kind of closes the door to one set of funding streams, but opens the door to a different one. And the new one you're opening is prevention services. So Colorado's moving to be on the forefront of jumping in on that and really trying to move the money in our child welfare system to be preventative. So an example would be if you take a child away from their parents and put them in foster care, that is unbelievably traumatic. And there's a lot of downstream implications of that, which if any of you have been removed from your families or had your children removed, you know it impacts the whole family. So we're moving all kinds of funding streams to support keeping kids in families and working with the whole family and the issues going on in the family, as opposed to creating them as two separate entities. The parents that did something bad and the kid that needs to be removed for their own safety. And that's a very different approach to what we're trying to do. Another thing we're doing is I also have the responsibility for our youth correction system in the state. And we find that about 80% of the kids who end up doing time, so these are kids under 20, have moderate to severe mental health issues. So it's another thing we're doing is really treating kids and adults when they get in the justice system, not just as perps or people that did something wrong, but again, seeing them as victims or people that have had trauma in their life. And so we're trying to address the trauma as well as trying to get them in a place where they aren't doing things that are illegal anymore. But you have to start from that trauma-informed perspective and really meet people where they are and understand most people don't wake up saying, I want to commit a lot of crimes. You know, lots of things have happened to them to impact their mental health that result in them being in the criminal justice system or the youth justice system. So it's a lot of it's about prevention. I hope you'll hear a lot about it in the next couple of years, is shutting the valve off on one set and moving to prevention.
You know, so much of this is, I feel like there's a lot of systematic errors that we've created in our current system right now. And something that you mentioned, Jennifer, is that you've encountered a system that sometimes does more harm than good. Can you give me some examples of things that you see in our current system that are wrongs that need to be righted or policies that just need to be changed or done away with?
Sure. I think, you know, as I sort of mentioned when we first started out, looking at programs that treat people the way that we think they should be treated rather than listening and observing and treating what people actually need. So people don't need punitive, you know, you missed your UA and so now you go back to jail. We've got to stop making that the answer for when people are using or in the throes of addiction or mental illness. We create programs that have incentives, and then if you are not behaviorally compliant, now you go back to wherever you came from, or you are now punished somehow. And it can be really traumatic, even in inpatient psych wards. I've worked in a lot of public health hospitals and psychiatric hospitals, and that becomes very scary and traumatic for individuals who end up in, say, padded rooms, as they call them, or the turtle suits, as a way of punishment. Solitary confinement is one that we love in the criminal justice system and that we now know actually causes mental illness. And we've got to start addressing some of these things. One of the things you brought up with early childhood care, foster care system, I mean, that's a soapbox all on its own, but also educating teachers to recognize that kid in the back of your classroom who can't sit still isn't just there to make your life miserable. Maybe he's got XYZ trauma. But you can't expect someone to recognize that if they've never been trained in that way. We don't allow the resources for some of these systems to function in a way that would be better and would be more beneficial, and we could do it. I think it's just wanting to do the prevention piece rather than answer to everything on the back end, which I think we've been really reactionary in this space. And it's maybe time to do something different.
Michael, it looks like you had something to add.
Yeah, I was thinking about the program that was highlighted here, talking about one of the programs about sending social workers along with police officers. I think that that kind of thinking is exactly what we need. Instead of treating folks struggling with mental illness as criminals, to actually acknowledge their humanity and their dignity. And I love that stat of 99% of the folks that there was a different outcome other than sending a person to jail. I think that we can't expect police officers to know absolutely everything, and using the expertise of a social worker in that example. I think we need to be just changing the way that we've done taking care of folks who are struggling.
No, and that's a great example of a really innovative program. So let me ask, I'm an ER doc, and of course in the ER we see a lot of patients who are struggling with mental health crises, people who are struggling with addiction, people who are there because they're homicidal or suicidal and things have reached a point of crisis where they've come in on a 72-hour hold. One of the great frustrations I think that ER docs and other physicians have is that we seem like we've built two parallel and non-communicative systems. A mental health system where we send patients to, and oftentimes I never speak with the psychiatrist, I never speak with the mental health specialist, it's done by their own evaluators. And then a medical system that's really just right now a catch, hold, and then when they get placement, release. Is that the right system? Are we well served by serving privacy needs and siloing? Or is there a system where we could have much more open communication between those two medical and psychiatric systems?
Yeah, here at DU, I oversee the health services and counseling services. One of the things that we've seen we've heard great things about from the patients is that as we do their health questionnaire when they check in, we have a social worker that's reading the screenings and looking for things around signs of depression, anxiety, substance abuse. And what she'll do is before the doc goes in, if they're here for a stomach ache or whatever it might be, the social worker will go in and introduce herself, say that she's seen that they're experiencing a lot of stress. Here's my name if you'd like to talk to me. So it's a soft kind of entry, and it's been really a wonderful way for us to bridge that mental health. As they're waiting for the doc to come in anyway, they're getting a contact. They've got a name now and a person, and we've found that students are really, really appreciative of that, and it's giving them permission to sort of reach out and get that support.
Yeah, I think one of the things that we're really pushing to do at the Graduate School of Professional Psychology is to create these embedded psychologist positions out in the community in medical settings, so that there is already somebody available in the sort of situation that you're talking about, because I don't think siloing is helping. What we're seeing is what we call frequent flyers, right? They go from your ED to my jail and then to X community mental health, and then they bounce because no one talks to each other and nobody knows what's going on with this person. And so trying to create more systems where we're talking to each other. Social work comes in if you're there for a stomach ache or you already have an embedded psychologist. I think that really starts to address some of what you're talking about.
And not only that, I'd say that because of the protections put around mental health, which have been long-standing and in many cases before the era of HIPAA, which protects all your rights in terms of your medical care, it was really important that we had these protections like 42 CFR. But now that we have HIPAA, we still have these old rules that now create two medical systems. And in my estimation, by having these two, mental health has been siloed and is kind of the ugly stepchild of medicine when it comes to so many of these things. And the reason why it's so stigmatized in the medical community is, I think, is because it's hidden away. And you hide away things that you're ashamed of, right? So is there a way to create a better, more communicative system?
It's interesting that you say that, because when you said two systems, I'm like, I would love to only have two systems. Today I sat with a whiteboard with some colleagues, and we came up with 63 different doors that you can enter the mental health system through. And the challenge that I'm seeing is, depending on which door you come through, we're not patient-centric, we're door-centric. So if you come in through a certain door, in order to go through another door that may be more appropriate, you have to go all the way back up to the front stoop and come in a different door and start over. So an example would be, using the example Dr. Clark mentioned earlier about the behavioral health specialist and the police officer going out together, if rather than bringing them to you or to jail, they brought them to a walk-in clinic where they could, that's one outcome. Sending them to you is a different outcome. Sending them to jail is a completely different outcome, because let's say when they did that, the person got a little nervous, as you can get nervous if you're living on the street or have mental health illnesses or challenges, and you might have spit on the cop. Well, that's a felony. That's assault. So now you're not just in jail, but you're in jail with an assault. And you may not be competent to stand trial because you have mental illness. So now you have to be restored to competency, usually in the state mental institution where there's a wait list. If you aren't competent, you need to be restored. That's another wait. They may be able to stabilize you on your prescriptions if that's part of your challenge, but as soon as you exit it, your Medicaid stops. And so you have to wait 6 weeks till Medicaid kicks back in, by which point you're unstable again. And it goes back to spitting on a cop. And so the system works if you just think at your sliver in it. But if you think from a patient perspective, our system has way too many doors, and the service you get depends on which door you come in. And God help the person that has IDD or intellectual or developmental disabilities, or no money, or is underinsured, or, you know, the system doesn't work if you're thinking from a patient perspective.
I've never heard that door analogy, but it is, you know, something that we see all the time and so true. And for so long, the only way that you can get a good MAT program is to go through the criminal justice system, right? And be put in a drug court where they mandated it for you, then it'd actually get paid for, you know? So it is kind of a bizarre world in some senses. Okay. So, you know, I want to be respectful of everyone's time, and I also know that there's a lot of audience members who probably have better questions than I do. So I'm going to ask one last question, and then 2 of these microphones are going to journey into the audience, and you guys can ask the questions that you want. And then we'll come back and we'll maybe do one last wrap-up, okay? So here's my last question for you. In the news recently, there's been a lot of news about opioid settlements, right? And, you know, in speaking with people in the know, it sounds like most of these opioid cases will be mostly resolved before the end of the year, right? So we potentially have the opportunity for a large sum of cash to be coming into Colorado to address, you know, opioid use disorders and mental health disorders in our state. Let's say you had $50 billion. Let's talk about a big number. How would you implement different policies, or how would you spend the money to change the behavioral landscape here in Colorado? And we'll start, Michael, with you at the end, and we'll bring it this way. Sorry to put you on the hot seat.
So I've got $50 billion. You know, one of the things I'm thinking about is we talk about upstream work. I think how I would develop a program, a prevention program, so that we are working with families and folks who are struggling early before the addiction starts. So I'm thinking more little kids. How are we helping support those family units that are struggling? How are we intervening before we get to that perspective? So I guess I would really be wanting to think about preschool, family support. I'll think more about that, but I guess I would be thinking about not necessarily how can we help prevent the issue to happen, I guess is my biggest question, and you caught me off guard with that.
No worries, and we can come back to you. So an ounce of prevention is a pound of cure is kind of the perspective you're forwarding, though. Okay, yeah. Well, Jennifer?
Yeah, I would really echo a lot of what Michael said, that really little, early childhood intervention, because I think that substance use also is born of attachment disorders and trauma, and so if we can start to address that in a way that's really helpful for the tiniest humans in our society, that would really do a lot of preventative work. I also think providing the same type of treatment to individuals who can't afford luxury rehab in Malibu, sort of taking what works and what we know works and being able to do it. If I had $50 billion, yeah, I would just create little luxury rehabs all over downtown Denver, right? And provide that kind of holistic care. So acupuncture, somatic therapy, things that we know really do work in this population that we just don't have the funding for. I think that's where I would start. Oh, training really competent clinicians, kind of one of my passions. Helping people really understand addiction and mental health in a way that is a little more nuanced and not so behavioral all the time. Yeah.
It's a good question. The state currently spends about $1.2 billion a year on mental health, behavioral health services. And if we got a big influx of money, I think what I'd want is to see one big door. And so people don't have to pick a door to come into the system. They can just walk up to the front door and have concierge service to direct them to where they need to go with clean assessments and the ability to be flexible. And then behind that door, I'd make sure there's a wellness room with workout equipment and cakes and all that stuff for everybody who's chosen to make this their field, so they really know how important they are and that we have a strong workforce. And then would love to be able to have enough people in the field that we could open the front door and go find people before they ever need to come to us. And so it's a prevention. So one door and lots of people in the front yard helping people not ever having to come to the door.
And then supporting those people in the yard, right? Because we burn out like crazy in this field.
That's why there's cake.
Yes. Oh. And thank God for that.
Okay, Michael.
I was just going to add one more point. I think that there is, in terms of prevention right now, I think you need amazing insurance, and I think leveling the playing field of who can get preventative care would be a big part of that, because if you're poor in this country, you don't have access to the prevention, or if you're marginalized populations, I would say that's true. So I would say that's how I'd be using it, to level the playing field a little bit.
And also sending some of that money towards, I mean, we have a lot of money going towards addressing the opioid crisis and epidemic in this country. We don't have as much still going towards meth and heroin, some of the things that are still really ravaging, especially Colorado. And so, like you said, sort of leveling that playing field. If you're poor, it's not so likely that you're downing oxy. You're probably shooting up heroin or meth. And so your chances to get treatment, because there aren't these big, huge, fancy grants for that, become much less.
So I've heard people talk, sorry, I lied to you. That was my last question. I've got one more, so I apologize. Hopefully you forgive me. So, one thing that was said in our opening, which was just so eloquent, I really love that quote, and it's going to stick with me for a long time, so thank you, is that when we replace I with we replace illness with wellness. And I've heard people talk about how the opioid epidemic is really just a symptom of a much deeper epidemic that we have of isolation and of mental, lacking that interconnectedness that really we need to thrive upon. So what are your thoughts about, is the opioid epidemic really just a manifestation of a greater mental health epidemic that we have in this country?
I mean, I think a lot of, almost all addiction is not just opioid. When I look at people who use opioids or meth or sex or porn, the common denominator is attachment issues and difficulty relating to others, feeling belonging, feeling accepted, feeling part of. So my answer would be yes, across the board.
I'm not sure this answers the question specifically about the opioid piece, but I would say Generation Z just arrived on our campus. They have had access to technology. One of my answers was telemental health, so I'm not anti-technology, but I think it's meant that these folks have created relationships in different ways. So my lens, of course, working with college students day in and day out, is that I think that the irony is, as connected that they are, there is also a loneliness and isolation with the population. So I think when we're talking about mental health in general, not just addiction, there is a disconnection. These computers that we're walking around with has created some unintended communication issues and leaving a lot of folks feeling awfully isolated and disconnected with maybe not as many communication skills. How do you work through some of the issues that were facilitated face-to-face before. I think that's completely changed, and our society is trying to catch up to the ways in which we have modified and changed the way folks communicate with one another. But I think a symptom of loneliness and disconnection is one of them.
Well, if I can offer a devil's advocate to that as the only non-medical professional here.
Plus a Facebooker, right?
Yeah, plus X. Opioids are different. It fundamentally changes your brain chemistry. And a lot of people may be addicted to opioids not because they have isolation or other things happening in their life, but because a doctor wrote them a prescription and they got addicted to it because they trusted their medical professional and found themselves in a situation that they could never have imagined. And whether it's opioids or benzos, I think we also have to look at the system not doing right by a lot of people who got walked into this crisis and didn't have pre-existing conditions that walked them through it. And so I think as a system, we need to take accountability as well for us failing a lot of patients as well as societal issues that may make someone opt in.
Couldn't agree. As a medical provider and a prescriber of opioids, I couldn't agree more. So, okay, great. So let's go ahead and give 2 microphones to the audience. We'll go ahead and steal. Great, yours and yours.
Thank you very much. My name is Rob Hernandez. I earned my graduate degree here from University College in healthcare leadership. And right now, the pressing issue that's being discussed by the Governor's eHealth Commission, as well as a lot of medical providers, whether it's integrated health or not, is regarding interoperability. And that is in regards to the health information exchanges, is that, and especially with this population that you're talking about with behavioral health care, is that you're going to see fragmented care. So you might have them go into one agency for health, and then you never see them again. But then they pop up somewhere else, and then somewhere else, because it's a mobile population. So I would like to take that $50 billion and solve the interoperability issue, because right now, healthcare policy and finance says, well, we can't do anything about it. Well, yeah, they can, or when you talk to the leadership at that department, they'll say, well, we've been working on this for years. Well, let's get to it and solve it, because fragmented care means expenses, it means costs, and it means people aren't getting the care that they deserve. So what can folks do to really try to make sure that interoperability succeeds? And not only that, but Director Barnes, you touched on people with intellectual and developmental disabilities. Thank you for mentioning that, because that is one population that always gets marginalized, no matter what the discussion is. So thank you very much for that. Thank you.
If I can just comment on that, thank you for your words. I actually attend a lot of the eHealth Commission meetings. They've been meeting for about 5 years, something like that, 4, trying to move forward on this. It is a huge initiative, but it's one that we can't do any of this without a new technology platform. I worked in the IT sector for a while, and so I can tell you a lot of the answer is new technology and new ways of interoperating between, whether it's being able to legally share data or just being able to functionally share data. We are not there now, and it's causing harm for people. And if you take the IDD population, they may not even be in a database, and then they walk into an emergency room or a provider, and there's no way to let them know that this is a comorbidity or an issue they've been dealing with, or a natural response to some of their disabilities. So thank you for that. One thing that people can do, and I mean this seriously, is please talk to your legislators. A lot of these changes, like the interoperability, is a budget issue and a priority issue. And I can't tell you how powerful your legislators are in terms of setting those priorities. And so if it's important to you, tell your legislator and ask for their help to get it on the budget docket and legislation.
Hello, my name is Maureen Welch. I live in Arapahoe County, and I have a 12-year-old son who has Down syndrome, so he has an intellectual disability. So thank you again for mentioning the IDD. I am a little bit wondering where HICPUF is tonight, because we hear all about how the regional accountability entities are supposed to be coordinating and uniting care between physical health and behavioral health. And my son and I just made a recent foray into mental health, and I had a little bit of a reaction when I saw the PowerPoint earlier because the mental health centers are not inclusive of my son. They do not serve people with intellectual and developmental disabilities, and I think it's actually completely illegal. They push it all over into the CCBs, the community center boards, to serve, and that's a real concern for us. And then also I would like to know how we might be able to access Director Barnes, because I do have a few questions about adult protective services, and I've attempted to email you and call you, and I just don't know how to get in to speak to you. So if maybe you could share how public can follow up, that would be wonderful. But thank you again for mentioning the intellectual and developmental disabilities, because we are always 10th class citizens, including in the mental health arena, and I hope that changes in the future.
Yeah, thank you for that question, Ms. Welch. I also have a beloved niece with pretty extreme intellectual and developmental disabilities, and so I keep her forethought, her forefront in my mind when working on this. You're right, we don't have good systems for people with IDD and mental health. It's a definite gap in our system. In terms of HICPUF, the woman who runs it, Kim Bimstetter, and I don't go a day without speaking. She's a co-chair of the Behavioral Health Task Force, and I will say, I feel like I'm bold. I think she's twice as bold as I am, and so I expect some of our recommendations to come out to be extremely bold in terms of system reform. So suspend any thoughts on it until you see what we come out with. I have a lot of confidence in HICPUF being a leader and doing some things differently. Regarding reaching me, I just declared email bankruptcy because I have like 8,000 emails I don't even think I've read. So go ahead and email me again at michelle.barnes@state.co.us. I'm relieving myself of feeling guilty about the other 8,000 and just starting fresh with a new inbox.
I'm Dr. Angie Piccioni. I'm the head of higher education for the state. And I mentioned this a little bit earlier, but as I speak with all of the presidents of the institutions, and I ask them what's the number one concern they have on campus, and to a person, they said mental health issues. The number of students who have attempted or committed suicide over just the last year would probably astound you if you knew. And so what do we do on campuses? I like your idea of having that the campus recovery piece, but what are some other things that we can do on our colleges to help our students with this issue?
Yeah, I think we just got back, the American College Health Assessment looks at mental health domains as well as other physical domains, and I think the surveys are echoing exactly what you're talking about. 20% of the students have seriously considered suicide in the last 12 months. 20% of our entire student population, that's amazing. I think we do have to, certainly individual psychotherapy, as a therapist, I think that's a very powerful tool, but it can't be our only tool. So helping people to thrive. Kim Lauer, Director of Health Promotion, is here today. She spends a lot of time in prevention. How are you training folks to connect, to talk? How are you connecting people into the resources, these early interventions? One thing that the university started in the last couple of years is behavioral intervention teams, is looking at faculty reports, so students who are not have a change in baseline, who are not doing well, connect the dots much earlier. I think we in higher ed have done a great job when a crisis happens, but what can we be doing? We need to change those issues, that someone who's feeling disconnected, not doing well, how can we know about that earlier on? And so we are using technology to connect faculty to the advisors. Developing the CRC is another example. The telemental health program has been another. I think the alarm bells are there, and we all have to be working together. I think faculty have been terrified about what's happening in this classroom, and they haven't known what to do. So how are we training faculty on early signs of identifying what these issues are? They've sort of said, I think historically, not felt comfortable or competent in that area. So identify those people who have regular contact with the students, get them tied into the system earlier before a crisis arises is what we're doing here, and I think you'll see more of that nationally.
Hello, my name is Edward Cannon. I'm an associate professor at the University of Colorado, Denver in the MA counseling program. Personally, I believe that safe, affordable housing is a human right, and I think here in Denver, we obviously have a housing crisis and we're criminalizing homelessness. So my bold idea would be to have safe, affordable, and on-demand housing for folks, but obviously that's pie in the sky. So what do you see as the biggest barriers to safe and affordable housing for Denverites? Thank you.
I'm not going to address if I had an answer to that, I would be in a different job. But it's a huge issue, particularly for marginalized populations, and that's where we're trying to put some focus right now. If you're exiting the foster care system and emancipating, you don't have a family to move back in, you're probably homeless. If you're exiting the criminal justice system and you have mental health issues or substance abuse, you're probably going to be homeless. If you're a youth exiting youth corrections and you have the same thing and you haven't been given an opportunity to rehabilitate, the same's going to happen to you. So that's where our focus is really right now in some of these marginalized populations. We're doing a project, and this is just a drop in the bucket, but we're taking Equality In with Colorado Coalition for the Homeless and turning it into apartments, rooms, that veterans exiting the state mental hospitals would have a place to go so they have a chance to re-enter society and not end up homeless. So what we're finding is Colorado Coalition for the Homeless is clearly one of the leaders in the state for this. And so we're trying to partner with them in every way we can to support them. Within the communities is where we're doing the more support for foster kids and disenfranchised youth. But it's absolutely part of the problem. Assume it's a social determinant of health, right? Yes, just didn't want to get that wrong. And it's one that as a state we need to be doing a lot more and as a community.
And I think your question is one that I think that we need to look at in the city, because I think as the city has exploded so quickly, further gentrification I point to 5 points in particular, I think this issue is only, on the ballot last year was what to do with the tent communities. I think the issue is going to get bigger and bigger, and I'm fearful if we don't head it off and solve some of this issue, that we're going to have far more complex problems in the very near future. I just think it's untenable what's happening.
Okay, looking at the time, I think we have time for probably one more question, and then we're going to try to get people out on time right around 8:30-ish. Great. So I'm going to leave this panel, and we'll start at the end with maybe just a last thought to end the evening on, to send our attendees home with. So, Michael, we'll start with you. I've really picked on you. I apologize. But
I think, in wrap-up, I think I'd like to tell some positive news. I think Gen Z, the students who are coming here, have, as you look at the whole picture, that there are some loneliness and isolation issues, but I think that we're seeing some really positive things. There's lower substance use amongst this population. Fewer have reporting less early sexual experience. So I think that it is a group that's deeply dedicated to the planet, dedicated to one another. We're seeing it's a compassionate group, and I'm very hopeful for our youth, actually. I'm seeing just a lot of positive things that they're coming to campus with. So I just wanted to add that part, that there are some of those liabilities that we talked about earlier, but I'm really hopeful for our youth and seeing a lot of care and compassion for one another and deep commitment to social issues, including our planet and poverty. So I'm very, very hopeful that this generation is going to be able to do things better than mine.
They also seem to be a lot more open about mental health, right? There's not the same kind of stigma or discomfort around it. I was, as I'm listening to all of us talk, I'm just struck by how multi-layered and systemic these issues really are. And even, professionally, we have our siloed conferences. And so I think summits like this that bring so many people from so many disciplines with interests that are, multifaceted together really will start to create some answers to these questions rather than all of us just hanging out in our professional wheelhouses and not speaking to each other. So I'm just really grateful that we're having these types of conversations.
And I think I'll leave on a final note is stigma is real. And it's another thing we're learning as we're going around the state is how important it is to reduce the stigma associated with mental illness and substance abuse. And I congratulate you, Stephen, for starting us by being so honest about your own situation. And as you noticed, Lieutenant Governor mentioned her brother and his struggles with mental health and ultimately taking his own life. And I think it's really important that particularly people in power and people with influence are brave enough to talk about their situation and try and normalize it. Like, if I have the flu, every one of you is going to know because I'm going to tell you 10 times. But wouldn't it be great if I could say the same thing? I'm feeling a little down today and I could use some support. We did a project this year, which I have to admit I wasn't too thrilled about. We had some opioid money to do a project called Recovery Card Project, which we got a bunch of people who were in recovery to design greeting cards and gifts and things. So it would help people if you knew someone in recovery or someone struggling with addiction or somebody whose family member or loved one was. It was to give them the words to support them, because you don't say, hey, you doing better with that opioid problem you have, or, sorry your son did. It's like, we don't have the words to do that. And I wasn't actually thrilled. I thought it was kind of a silly project until the first day we give the cards away, and 10,000 cards disappeared off our website, people ordering them, and now we've got hundreds of thousands more, so you can order them for free. But what it told me was that a lot of us don't know how to deal with stigma, and we don't have the words, so we avoid it and we run away, as opposed to saying, that was a beautiful thing you did to start us. We need to run into the concern and not run away from it. And so that's one of my big messages is every one of us can do something about stigma, even if it's just looking at your own biases and your own insecurities, and just ask that follow-up question and support people who need us.
So my final thought is one of, we started off talking about isolation and I, and how I should be we. And I think I'm going to turn that around and say, we're facing right now one of the greatest public health epidemics, threats, whatever you want to call it, in our nation's history, with the opioid epidemic and the mental health epidemic that we have in the country. And instead of looking at the stage and looking at these experts and saying, oh, it's great what they're doing, I want each one of you to ask, what am I doing to really help our country and help my community solve these issues? Am I being a good neighbor or friend to my patient who's struggling? Or to my classmate or my roommate who's struggling? Am I checking in with them? If I have someone who I know and love who has an opioid use disorder, do I have Narcan with me so that if they do overdose, I'm able to reverse them, right? Am I being that open door that people can feel like they can speak with? And then on the other hand, if you do struggle with one of these issues, know that you're not alone. Know that there's so many people like you who are struggling, and it is the bravery to go out and seek help when you need it, right? It's nothing to be ashamed about. It's something that we all, and by you stepping forward and saying, I need help at this time, I'm having a bad day, I'm having these thoughts, I think it makes you stronger, and it also models for other people that looking for help is okay. So maybe I will leave by, I guess you're going to have the final word here, right?
Yes, maybe. So I just wanted to thank everyone so much for joining us tonight. This has been a really amazing conversation. Thank you, Dr. Clark, for your contribution. Thank you to each of the panelists. Really appreciate your insights. And the good news is this is just the start of the next 3 days. So we hope each of you in the room will find a workshop or 2 or 3 or 4 to join us, because we've got some amazing content. We've got speakers flying in from around the country. So please take advantage of it. So hopefully I'll get to see you throughout the week. And if you have questions afterwards, please stop down and see us. So thanks again, and get home safely.